Light this up then.
I just touched the screen. Yeah, there we go. Okay. All right. So the next disease state is rheumatoid arthritis. So the drugs that are used for rheumatoid arthritis are called DMARDs, disease-modifying anti-rheumatic drugs. If you've ever heard that term before, that's where it comes from. I think it's a weird term because to me, any drug should be disease-modifying, but I don't know. That's where they come from. So to initiate this, I grabbed an old picture of somebody with RA, and I don't know. I thought that was cool. So, quick facts. RA, rheumatoid arthritis, is the most common form of autoimmune arthritis. It affects about 1.3 million Americans, 75% of which are women, and typically the patients are between 40 to 60 years of age. It's been shown that early treatment strategies offer the best prognosis, as well as the continuation, hopefully, of an active lifestyle, which will essentially complement treatment. The diagnosis is multifactorial. You can see patients presenting with anemia, rheumatoid factor, of course autoantibodies, elevated erythrocyte sedimentation rates, which is essentially a marker of persistent inflammation. All this is coming from the American College of Rheumatology, with the link shown there at the bottom. Relatively small prevalence, though. It only exists in about 1% of the population, and it doesn't discriminate against race or ethnicity. There has been shown to be some genetic predisposition, particularly among the patients that have the HLA-DR4 phenotype, as well as the HLA-DR1 on their T lymphocytes. Other things that can potentiate the incidence or the presentation of RA include patients that smoke, that have pulmonary diseases, as well as a history of certain infectious agents such as Epstein-Barr, E. coli, and there also is an association of periodontal disease with many of these patients. So we spend a lot of money on RA, and actually if you've seen a lot of the commercials, you've seen some of these drugs. The cost of these drugs, because now we're getting into kind of the personalized or the targeted medicine, is skyrocketing. And so some of these figures are from basically a report called Trends in Biologic Therapies for RA, and this was published just in 2012, and they've probably gone up since then. So normal joint essentially looks like this figure on the left. Joints that are affected with RA have this inflammatory component that actually disfigures the fingers and can actually lead to the joints being dislocated over time. And so patients with unmanaged or advanced RA, you'll kind of see this presentation. And it can be in any joint, but this is just showing the hands. Different criteria for RA. Essentially, if you've got at least 4 of these, you're probably in good standing for treatment. And there's extra articular involvement. You can get rheumatic nodules, vasculitis. There's ocular manifestations. There's cardiac involvement. And then there's also a syndrome that we associate with RA where the patient has splenomegaly and neutropenia and perhaps thrombocytopenia. Okay? So the traditional approach for these patients has been NSAIDs, and that really just kind of treats the pain, really very little effect on disease progression. So these disease-modifying anti-rheumatic drugs, the DMARDs, were reserved for essentially the most severely affected patients, and then those that have destructive diseases. Remember, this is an autoimmune component, and this autoimmunity is actually driving the arthritis. So the early DMARDs were often ineffective, or they were so strong they were poorly tolerated. And now we've done a little bit more research in terms of when best to implement some of these drugs, and we've kind of changed the treatment paradigm for many of these patients. In the 50s and 80s, this was the typical treatment progression, starting with aspirin and then ending with DMARDs. The new approach has essentially shown us that we need to flip that pyramid upside down, and we need to be more aggressive in the early phases of the disease. There is a little bit of a complication in terms of the diagnosis. Some of this inflammation, especially within the synovium, might be subclinical. Some of these early erosions may not be visualized on current imaging modalities. And of course, many of these agents that are disease modifying are extremely expensive, and the side effects are kind of unpleasant. So now what we do is we essentially start with aspirin, NSAIDs, steroids, and 2 or 3 DMARDs, and then we gradually withdraw treatments once remission is initiated or achieved. Okay, and so this is kind of the current RA treatment strategy pyramid. So it's the upside down version of what we were using for 20 or 30 years beforehand. So initial therapy began with several agents all introduced at the same time, and you gradually kind of reduce to a quote-unquote maintenance agent. Some of these agents include sulfasalazine, methotrexate. You've heard of methotrexate before. Prednisone, I love it. And what we've shown is that when you've got all these drugs on board, you have improved efficacy, and that's been shown in several large clinical trials. So this whole notion of combination therapy, what does that sound like? Sounds like chemo, right? You've got multiple drugs with different molecular targets and hopefully non-overlapping toxicities. That supports the Goldie-Coleman hypothesis. We traditionally think of Goldie-Coleman in terms of cancer, but essentially you can apply it to other diseases as well. So you'll start these patients on several of these different drugs. We're not going to talk about the therapeutic management strategy because we only have an hour, so we're going to talk about this in generalities. We'll examine each group of drug kind of individually. So again, early assessment and treatment, you want to use relatively aggressive ultrasonography. So far they've shown that ultrasonography is essentially 6 times more sensitive than conventional radiographs, and you can kind of detect some of these erosions that are indicative of early RA. So you'll start with step-down combination therapy and then transition over to biological agents, which we'll talk about. So of course, aspirin, again, commonly used in RA. It's pretty effective. 90% of patients experience at least some type of relief with aspirin. Yet many of these patients will not be able to tolerate the higher doses. So because of that, we end up having to switch them to another anti-inflammatory type of drug, any of the ones that we just talked about. There's kind of a sideline note here. We don't want to give aspirin with other NSAIDs in the context of RA or any other disease. And so let's go back to that diagram just for a second here. Here you've got your aspirin alone. Here's your COX-1 enzyme. Okay. Here's the active site, which is essentially bridged by serine. Okay. Aspirin goes in, acetylates this residue irreversibly. Okay. Salicylic acid comes out. Now, when you give ibuprofen before aspirin, there's a steric hindrance reaction here. Remember from organic chemistry, steric hindrance? Ibuprofen, which looks like this, goes into this cleft within this enzyme. And if you wait a period of time and give aspirin, ibuprofen is still in there. Aspirin cannot get in there, and arachidonic acids essentially have no effect. So this is one of the reasons why if the patient's on aspirin for an antithrombolytic, post-STEMI, post-stroke, you don't want to have them taking ibuprofen or any other NSAID for that matter, because it will negate the activity of the aspirin. There will be no therapeutic benefit to putting aspirin on board because the ibuprofen is there. Because the ibuprofen is reversible, okay? If they don't take high doses of it, which they're not going to, the arachidonic acid can be put in there, and the prostaglandin pathway can go forward. All right, does that make sense? So that's why if you look at patients that are on aspirin for STEMI, it says to have the best therapeutic benefit, avoid NSAIDs. So then that's the compounding difficulty. If you've got a patient who had a STEMI who also has gout, right, that's going to be a problem. Your NSAID therapy is not going to be very effective in those patients because of a timing issue. Okay? So it's just, kind of something to keep in mind. So aspirins and or NSAIDs would work, but let's talk about the DMARDs. All right, we've got a few drugs that have really different mechanisms of action. These are all used in the successful management of patients with RA. Methotrexate. We've talked about methotrexate in different capacities. We'll talk about it again. Remember, it's an immunosuppressive agent that inhibits folate metabolism. And it also alters levels of adenosine and TNF-alpha. TNF-alpha, remember, is a pro-inflammatory cytokine. The frequent side effects and other specific indications and nuances are listed here. You can read about that by yourself. Sulfasalazine is a sulfa drug that's whose mechanism of action in the context of RA pathogenesis is not entirely understood, but we know through trial and error and mistakes that sulfasalazine can actually offer some therapeutic benefit to these patients, although we have no idea how. Salts of gold are taken up by macrophage, and that's going to inhibit the ability of the macrophage to induce or to stimulate the process of phagocytosis. That's going to reduce rheumatoid factor, which is going to reduce the amount of immunoglobulin levels that are going to be driving pathogenesis. I don't know if it was inherently obvious, but if it's an autoimmune disease, right, there's a B cell component of autoantibodies that are IgG that are going to be driving macrophage activation and cytokine release that's going to contribute to inflammation and pain in the joints. That's kind of the nail on the head. Hydroxychloroquine can suppress T cell activation through a couple of different mechanisms, and leflunomide can inhibit the synthesis of a uridine phosphate, which occurs within, and the response can typically occur within 1 month. So it's not an immediate therapeutic benefit, but it's something that can be used in the long-term therapy for some of these patients. So, really different mechanisms of action with all these different DMARD-type drugs. All of them are successfully used in the management of RA, and many of them are combined with each other. All right, and we'll just kind of leave it at that. Let's talk a little bit about some of these DMARDs in a little bit more detail. Methotrexate, remember we said is a potent anti-inflammatory. Variety of mechanisms of action. We've talked about methotrexate's ability to inhibit cytokine production. Remember, cytokines are going to be driving the immune response, that autoimmune response that's driving the pathogenesis. It'll inhibit purine biosynthesis, and it'll stimulate the release of adenosine. You can give methotrexate intramuscularly, sub-Q, oral, and also remember that it's a folic acid antagonist, and so it can induce a folic acid deficiency, and therefore if the patient has RA and is planning on getting pregnant, this is not the drug of choice for that particular patient. Leflunomide essentially inhibits pyrimidine synthesis, and so that's going to result in a decrease of the proliferative ability of the lymphocytes. Lymphocytes rely heavily on pyrimidine synthesis to grow and divide. Leflunomide can cause liver toxicity, and so you're going to have to monitor these patients, particularly with respect to alanine aminotransferase activity. Leflunomide is a known teratogen, so again, if the patient's thinking of becoming pregnant or there's a potential risk of developing pregnancy, probably not the drug of choice. This drug also sticks around for quite a long time, so that's something to think about in terms of drug-drug interactions and toxicities and overdoses and so forth. Another drug that you can use for these patients is azathioprine. This is that prodrug that can be converted into 6-mercaptopurine, and this is one that inhibits DNA synthesis. We've talked about it in immunosuppression, and I think we mentioned it briefly in cancer chemotherapy. But essentially, it affects rapidly proliferating cells, and so if the immune system is driving this pathogenesis of RA, we can target T and B cells, which are increased in proliferation, to kind of reduce some of the side effects and inflammation that we see within the joints. Believe it or not, minocycline, the antibiotic, which is a tetracycline derivative, has been shown to offer some therapeutic benefit in patients with RA. This mechanism of action, we don't know. We think that it inhibits matrix metalloproteinases, which are degradatory enzymes that can degrade collagen within the cartilage, but that research is ongoing. We don't really know how that works. Other DMARDs include D-penicillamine, so this is a chelating agent. You'll see it used in Wilson's disease, but it's also a known macrophage function inhibitor altering activity of interleukin-1. Right? Cyclosporine, the calcineurin inhibitor that we talked about as an immunosuppressant, binds to cyclophilin, and that's going to alter the activity of T cells. Cyclophosphamide, the chemotherapeutic drug, is an alkylating agent that binds to guanines and essentially alters DNA replication and is naturally immunosuppressive. So the drugs that are classic immunosuppressants, antimetabolites, early chemotherapeutic agents can all have successful implementation in treatment strategies for RA patients and can be classified as DMARDs as well. So just a little bit of background, aspirin is a relatively small molecule, 21 atoms, and actually in chemistry class I made aspirin. I wouldn't take it because I'm not a good chemist, but it can be made. These biologically engineered DMARDs are very, very large moieties. Obviously, there's a sophisticated biological production process, and what does that mean? It takes time and money. So these drugs, these newer DMARDs that are coming off the market that are classified as biologics, extremely, extremely expensive, all right, compared to the conventional small molecule generic drugs like your NSAIDs and aspirin and some of these other, like methotrexate, relatively cheap. So originally we tested these biological agents in the classic DMARD-resistant progressions, and now we're starting to understand that we can use these drugs in the early stages of pathogenesis. And so what does that tell you? I mean, what are these biological agents targeting? They're targeting TNF, they're targeting interleukin-1. That's saying that these cytokines, these pro-inflammatory cytokines, are present in the early stages of disease pathogenesis and make attractive targets because they're driving the disease progression. They're not a consequence of the disease pathogenesis, they're the cause of it. And that's why we need to aggressively target them early on. So, the drugs that can target TNF-alpha, we've talked a little bit about some of these drugs. These are monoclonal antibodies, infliximab, adalimumab, etanercept. The drugs that can target interleukin-1 include anakinra and a couple others, which apparently I forgot to put on there. These drugs are all of your classical biological agents that are now offering, really good utility in terms of managing patients with RA. So remember, TNF-alpha is derived from macrophages. It's in the context of RA, it's been shown to be the major contributor to inflammation within the synovium, so within the knee joint, right? Infliximab is a really good monoclonal antibody to TNF-alpha. It's going to remove it. It's going to clear it from the joint in the bloodstream so that it cannot produce its pro-inflammatory responses. You'll see reduced infiltration because of that, because remember, these pro-inflammatory cytokines like TNF and some of these others, these are the ones that are honing the lymphocytes to the site of inflammation so that more inflammation can exist, and that inflammation causes pain, swelling, joint discomfort, and that's the pathogenesis or the progression of RA. All right? This is what infliximab looks like. It's a humanized monoclonal antibody. I think that's all I need to say about that. That's fine. It's associated with the cytokine release syndrome. It's relatively rare, but it has occurred. You get headache, fever, chills, and that's because of all these cytokines being released from these different immune cell mediators. It also has been associated with a lupus-like syndrome. In terms of using these drugs, you have to make sure that the patient hasn't had TB or has a latent TB, because it can exacerbate some of these different underlying conditions. We also see patients experiencing back pain. So you treat the knee pain and then the patient gets back pain, so it's not fair. Humira, you've probably seen the commercials for Humira. The generic name is adalimumab. It's a monoclonal antibody to TNF. This is all human, where the other one was partially mouse. Same mechanism, different response rates. Side effects basically at the injection site, but are relatively mild and relatively well tolerated. And it has that same kind of warning to make sure that there's no underlying infections and there's not a latent TB infection. Enbrel, or etanercept, it's a soluble dimeric form of the TNF-alpha receptor. So the other one was inhibiting the ligand binding to the receptor. Now this is actually inhibiting the receptor itself. Basically, it's going to inhibit any kind of signal transduction through this TNF-alpha pathway. It's approved for treatment of RA, but you also see it in other inflammatory type diseases, which are mentioned there. Side effects include sepsis, infection, injection site pain, and abdominal pain. Rituximab. So again, we've talked about rituximab as as an immune suppressant. We talked about it as a potential chemotherapeutic agent, especially for B-cell driven lymphomas. Now we're talking about rituximab as a drug for targeting RA. Because remember, the source of the RA pathogenesis is these autoantibodies. Which cells produce antibodies? B cells. If you inhibit B cell activity, you inhibit the ability of these autoantibodies to be even produced. Now we're looking at clinical trials where we look at this drug in combination with something like methotrexate and other TNF-alpha anti-therapies. Anakinra is a interleukin-1 receptor blocker. This has been indicated for moderate to severe RA in patients where some of these other drug classes have traditionally not worked. There has been some off-label use in gout, which is the next lecture. And the response is relatively quick, 4 to 6 weeks maximum, but as slow as week 13. So from the administration of the drug to the noticing of the effect. And then again, side effects include injection site pain or reactions, infections, and neutropenia. Interleukin-6 is another pro-inflammatory cytokine. Again, there's the indication to screen for baseline TB, subclinical hepatitis C and B, also liver function tests before you're going to implement this type of drug for these patients with RA. And I think the last group of drugs within this category is a tafasitamab, which is a JAK-STAT tyrosine kinase inhibitor. This is particularly useful in patients that have failed methotrexate therapy or for whatever reason can't handle methotrexate therapy. And remember, the JAK-STAT signaling cascade of the tyrosine kinase essentially is going to inhibit the downstream cytokine signaling pathways, which inhibit downstream leukocyte movement. And so, this is hardcore immunology, but if you inhibit JAK-STAT, you inhibit cytokine signaling. Less cytokine signaling produces less leukocyte recruitment or movement from the vascular network into the site of inflammation, in this case, the synovial joint or the joints in the elbow or wherever the RA is manifesting itself. So we've started looking at interleukin-1 in terms of RA, but a lot of these chemokines and cytokines have clinical use. They have portions of their signaling properties are exploited in other diseases, and so I mentioned earlier that interleukin-1 is a classic kind of rheumatoid arthritis molecular target. Now we're beginning to realize interleukin-1 also plays an important pathogenic component to gout. And this slide basically kind of summarizes how there's a IL-1 component to the gout as well. Okay. So what does that mean? We've got tons of therapies that are emerging for RA, okay? And all of these are basically targeting the immune system. Anything mAb is obviously a monoclonal antibody, Okay, and look at some of these therapeutic targets: IL-1, IL-1, IL-6, IL-1, IL-17, CD20, CD20. Some of these other rankle mammalian target of rapamycin, the JAK-STAT pathway, phosphodiesterase E4, tons of immune therapies that are in various phases of clinical development, and you'll probably see more of these coming out in the pipeline in the next 2, 3, 4 years. You know, so this is going to that personalized medicine idea that we kind of elucidated in the chemotherapeutic lecture, talking about targeted therapies. You know, so if the patient has a hyperactive IL-1 pathway that's contributing to their RA, you know, we're going to have an arsenal of several drugs that we can use to treat their RA and reduce their symptoms. And that leads us into gout. Let's take a few minutes break, and then we'll finish up with gout, and we'll be done, okay? Gout. How's it going?